Well, thanks again for to everyone who's joining us. My talk is going to be around our refractive cataract surgery outcomes. Some of my slides are from Alcon. I'm just disclosing that. I think those will be obvious, and I'll keep on moving. In 2013, it was estimated that the demand for eye care services is going to increase about 23% over the next 12 years, while the supply of ophthalmologists over that corresponding time is projected to go down 11%. Similarly, as the population ages, it's expected to double in the over 65 population in 2006 and 2030. And correspondingly, the number of cataract surgeries is predicted to increase by about 5% per year as that aging population needs more and more cataract surgery. Now, patients clearly want information about cataracts. This Google study was done in 2015, and it showed that there were about 1.9 million Google searches for cataract surgery on patients who had recently been diagnosed with cataracts. As patients approached surgery, another 1.2 million looking into the options for surgery. And postoperatively, patients obviously go to their optometrist and have lots of questions about their cataract experience. Now, Alcon did this study where they looked into patients who were being diagnosed with cataracts at their optometrist's office, and they found that only about 1 in 4 really knew much about cataract or cataract surgery. They were just generally given the diagnosis. They were given the diagnosis of cataracts and really didn't know much about it. And frankly, when they arrived at the ophthalmology office, they still didn't really have much knowledge in terms of specifically about options and lens options. And they also found that if patients were really well informed as to what their options were, many of them did embrace some of the premium options like monovision or astigmatism correction or presbyopia correction. So custom cataract surgery at Tucson Eye Care basically relates to premium lenses, either toric or presbyopia correcting lenses. We also do custom near or distance, which is for patients who are typically post-refractive, high myopes or hyperopes, patients who want monovision, and patients who are perfectionists who just really want precise vision at a certain distance. And what we throw in for the custom near and custom distance, in addition to all the other diagnostics and therapeutics we do, is the intraoperative aberrometry. Okay, so there's some critical steps to optimizing outcomes in cataract surgery. The first, obviously, is to make sure the diagnosis is correct, that the patient does have significant cataract, and that the cataract is consistent with the patient's symptoms. One of my favorite clinical tools is if the patient has cataracts that look the same in both eyes, but there's a significant difference in acuity between the two eyes, clearly there's something else going on. So part of the evaluation is to identify and treat comorbidities, thorough exam, corneal topography, macular OCT. We use these IOL Master 700, which does precise biometry, integrating modern IOL formulae, and that helps assess accurate effective lens position, and also measures posterior corneal astigmatism, which we've learned is a variable that we didn't pay attention to a while ago. We have the option to use intraoperative aberrometry, which we do. And again, we try and do the best surgery and post-op management that we can. In terms of comorbidities, dry eye, which Sarah Fry will talk about in a few minutes, is a huge one. In the cataract population, there's a recent study that showed that about 85% of patients who present for cataract surgery will have either corneal staining or an abnormal point of care test, either tear osmolarity or MMP9. Irregular corneal astigmatism is a big one. Again, our topography will help with that. The diagnoses of those you're all familiar with, as well as maculopathy. Now, the PanOptix lens is the first trifocal that was FDA approved last fall. It obviously works towards providing spectacle independence, giving excellent near, intermediate, and distance vision, and is also available in toric form for people who've got astigmatism and want presbyopia correction. The slide on the right shows a simulated vision where you can see your iPhone, your cup of coffee, and the end of the coffee shop, which would be ideal for patients who have presbyopia correction. In the FDA study, where they had 129 patients with bilateral PanOptix lenses, 99% of those said they would choose the same lens again, and 98% of those said they would recommend that lens for their family. So pretty strong endorsement from the patients who underwent the studies in the US. And what makes the lens different is the optics is concentrated within the central 4.5 millimeters. Light is split up into distance, intermediate, and near. And even if a pupil is small at 3 millimeters, about 88% of the light is distributed through that pupil. So the lens is less pupil dependent. Again, it focuses specifically at distance or infinity, 60 centimeters, which is computer, iPad use, and near at 40 centimeters. This slide shows that with the PanOptix lens, it is possible to have good acuity at all distances through a full range. This was during their study, they looked at patients' intolerances and frustrations. And the only real significant one was about 4.8% of the patients who were bothered by starbursts. Halos and glares, less bothersome, but starbursts were a source of concern. Interestingly, this lens, despite its optics, shows no real difference in loss of contrast sensitivity when compared to monocular lenses. Both in the mesopic and photopic situations, the loss of contrast sensitivity is comparable to a monofocal lens, which is pretty incredible. So who is a good candidate for this PanOptix lens? In essence, they need a very healthy eye other than their cataract. Preferably, they've not undergone any prior refractive surgery. They have no glaucoma or retinal pathology, no irregular astigmatism, no unmanaged dry eye, and the corneas are pristine. In terms of activities, it's important to ask what patients' interests are, what their hobbies are, what their activities are, and what they're looking for in their vision. One additional question we ask all of our patients is if they're perfectionists or not. You know, if the person who has the personality of an engineer or a pilot may be a poor candidate for this kind of a lens, whereas the more easygoing patients definitely would be better candidates. So I wanted to share the results in our practice of PanOptix. This graph shows the first 70 eyes we did, and we're looking at monocular, uncorrected acuities 3 weeks post-op. The blue bar shows 2020, the green bar is 2025, 2030, and you can see the overwhelming majority of patients have excellent vision, 20/30 or better, at distance, intermediate, and near. There were some patients who had poorer vision at distance. Frankly, 2 of those had residual refractive errors about minus 0.75, and 1 had a untreated capsular opacification. When we look at binocular acuities in those patients, so 35 patients with 1 PanOptix in each eye, uncorrected at 3 weeks post-op on their second eye, you can see that every single one of those patients was 20/30 or better at distance, intermediate, and near, which is incredible. We've never seen anything like that before, frankly. When we look at our toric outcomes, we analyzed 102 of our most recent toric patients who had at least 3 weeks of post-op care. The mean cylinder of the patients was 1.74 diopters with a range of 0.9 to 7.83, standard deviation of 0.93. The mean postoperative cylinder, again at 3 weeks, was 0.45 diopters with a range of 0 to 2.25, standard deviation 0.45. What we found is 90% of our toric patients were 20/30 or better uncorrected, and 99% were 20/40 or better uncorrected. And I'll have a graphic representation of the same thing. The ones who were 20/40, 20/50, the 20/50 patient was the patient with the highest astigmatism, who had a residual astigmatism of 2.25. But there are some comorbidities that account for the 20/40 patients, some macular issues and so on. When we look at custom distance and near, again, these are patients who specifically want good distance or near vision, either because they're high myopes, high hyperopes, they've had prior refractive surgery, or they're doing monovision. Our results for this group showed that 90% of patients where we aimed for custom distance, we were able to achieve 20/30 or better, again, 3 weeks post-op uncorrected. 97% 20/40 or better. When we looked at the near patients, 31 of 31 had 20/30 or better at near at 3 weeks post-op. And again, here's a graphic representation of those 166 patients for custom distance and near. Now, probably the most challenging group are the post-refractive patients. The big challenges in post-refractive patients, as you know, is that their corneas are often irregular. And when we calculate effective lens position, the traditional formula projects a deep lens position for somebody who's got steep Ks. They assume steep Ks go with a myopic eye, the lens sits further back. But once they've had their refractive surgery, which flattens their Ks, the formula kind of mess up that calculation. So there are some additional steps in the calculation where we factor in anterior chamber depth and white-to-white measurements to try and improve the calculation, but we still are not perfect in the regards of predicting effective lens position. Nevertheless, 66% or 2/3 of our patients who had prior refractive surgery were 20/30 or better uncorrected at 3 weeks. 80% or 78% were 20/40 or better. But we did have a good 22% of patients who were 20/50 to 20/70. And the truth is, for those patients, the usual explanation was that they still had some irregular astigmatism. Most of those patients, frankly, were RK patients, and some of them were LASIK patients who just had irregular ablations. So the main point I wanted to share with regard to this talk is that you as optometrists who are diagnosing cataracts have a potential to help educate patients, specifically in terms of what they may expect, what some of their options might be, and frankly, what lens choices may be in their best interests. You often know these people better than we do. And I would ask that you take a few minutes to just talk to them about their potential options. You know, do they have astigmatism? Is that astigmatism regular? Is it irregular? Are they interested in presbyopia correction? Have they been successful monovision contact lens wearers? And I think that getting them thinking, getting them researching, so that when they show up at our office, they're more informed and more educated, is going to end up giving us more happy, satisfied patients. Well, I thank you for your attention and time. I'm going to turn over to the next speaker, so we're going to pause the show for just a minute.
Good evening, everyone. Thank you for joining us tonight. My topic is going to be dry eye with a focus on meibomian gland dysfunction. So just to kind of go over what I'll be talking about, it's going to be very short, starting with just reviewing some tried and true dry eye treatments, and then going into focusing on thermal heat pulsation specifically and its applications. And then finishing up with just talking about some up and coming dry eye treatments. So this is just kind of a laundry list of all the dry eye treatments that we use, starting kind of up at the top at our most basic level, and then kind of graduating down to more and more involved treatments. So anything from artificial tears to punctal plugs to amniotic membranes, and these all definitely have a place in dry eye treatment. So just reviewing kind of our initial traditional classification was really trying to separate people into aqueous deficient versus evaporative. So trying to figure out which patients had problems with the lipid component of their tear film falling into that evaporative category versus those that simply were lacking in the aqueous component. The reality is that traditional classification has fallen by the wayside, in that the reality is the vast majority of patients have some level of evaporative disease and some level of meibomian gland dysfunction. So really that classification is no longer really valid. So in that, we've seen the development of a lot of devices in order to help with that evaporative component of dry eye, with the LipiFlow kind of being the standard of care in the thermal heat pulsation category. But following that, we've had the development of several other devices at a lower price point and maybe more portable that are able to help with meibomian gland secretions. So who's this guy? This is Henrik Meibom. For as much as I talk about meibomian glands, I actually did not remember, maybe didn't know, the origin of the name meibomian glands. So this is the physician who initially characterized the sebaceous glands of the eyelids, and therefore was later ended up becoming responsible for the name of the meibomian glands. So when we're looking to see who might be a candidate for thermal heat pulsation, there's a few different diagnostic tools that we can use: the slit lamp exam, meibography, and then expression of the meibomian glands. So I'm just going to talk a little bit about each of these. With the slit lamp exam, there's a lot of different things that we can look for that might point us to a problem with the meibomian glands. Sometimes we might see some stagnated meibum, some opaque meibum along the lid margin. We might see some vascularization of the lid margin, a frothy appearance to the tear film, reduced tear breakup time. So a lot of these things can point us in that direction. Another tool that we can use is meibography. And on the left, we see an image of normal meibomian glands. We see good architecture of all of those white structures. There's plenty of them. They're even, they're full, they look great. On the right, in comparison, we see a fair amount of atrophy and truncation of the glands. And so this can be a really useful tool to show patients, because when we're doing our slit lamp exam and we communicate our findings, it's really a picture's worth 1,000 words. And so this you know, can be very useful to show patients. However, by the time you get to the point where somebody has truncation or atrophy of the glands, it's already somewhat advanced condition. So sometimes we don't want to wait until that point. And then the final tool that is very useful in evaluating patients for meibomian gland dysfunction is using expression. So although we can use kind of our fingertip along the lid margin, the amount of pressure that we apply isn't always even. So that's what this tool is for. It enables us to apply even pressure every time we use it all along the lid margin. So when we look at the anatomy of the meibomian glands, the upper lid has about 30 glands and the lower lid has about 25 glands. We generally just use the meibomian gland expression tool on the lower lid. And although we have 25 glands on the lower lid, we don't expect them to all be active at any given time. So some may sort of be dormant and others active. So we expect about 15 glands to be expressing. So we can run this device along the lower lid 3 times. So kind of on the lateral margin of the lid, in the middle, and then in the nasal area. And then we should be seeing about 15 active glands secreting. And so this is a really good tool in evaluating pre and post treatment. So although meibography is a useful tool in diagnosis, it's not one that we expect to change in appearance post-treatment. So we don't expect regeneration of the meibomian glands per se after a LipiFlow treatment. There have been some case studies where we've seen some meibomian gland regeneration, but generally we're looking for things like improvement in tear breakup time, where this cohort of patients went from a tear breakup time of 2.9 prior to their treatment to 6.6 post-treatment. And then also an improvement in their meibomian gland expressibility score. So that's using that device to see how many glands we're able to express. Again, that scores out of 15. And so we're seeing an improvement from 4.7 to 13 in this cohort of patients after thermal heat pulsation. So we're looking for better meibomian gland expression and improvement of symptoms. And so just to wrap it up, I just wanted to talk about a few up and coming treatments. Intense pulse light, or IPL, is a device that you've likely heard about from Luminous. That's another great treatment for meibomian gland dysfunction, sort of an alternative to thermal heat pulsation, if you will. And it kind of has that side benefit of improved cosmesis, which patients appreciate. There's also a new biologic called Regenerize. It's derived from the placenta, and it contains various growth factors and anti-inflammatory cytokines, and it sort of acts as an immunomodulator, you know, kind of regulating inflammation in the tear film. And so that's another tool that I've put 3 of my patients on so far, and I'm just kind of waiting to see how they respond to it. So it's an alternative to Restasis. A lot of patients don't tolerate Restasis due to the stinging, so this is kind of an option for people that are looking for something more. It doesn't target the meibomian glands per se, but there have been some case studies showing some meibomian gland regeneration with the use of Regenerize. And then the final device that I wanted to talk about was this intranasal tear neurostimulator. It was called TrueTear, made by Allergan. And it was actually only out for a short time. In the last month, it's actually been pulled from the market. But the concept with that is it's a device that is inserted into the nostrils and stimulates tear secretion. And we would expect that that would be more reflex tear secretion, really aqueous heavy tears, but they've actually looked and studied the tears and seen that they actually have a composition that's comparable to normal tears. So so this device was actually able to stimulate mucus production from the goblet cells and meibum from the meibomian glands, as well as aqueous, and kind of stimulate some natural tear production. But basically the manufacturing was very expensive. So the device was very expensive to patients. And in order to overcome that, we would have really had to have high volume sales, which didn't happen. So just in the last month, this device has been pulled. So I'm sure there's going to be plenty more treatments coming down the pipeline, and I'll keep you updated as we go. Thank you for your time, and please hang tight as we get the next speaker situated.
Okay, well, welcome. I'm Dr. Rand Seekert. It's really nice to see a lot of friendly faces out there. I certainly wish during these difficult times we could meet in person, but the next best thing is to have these Zoom sessions. So thank you for joining us. I'm going to give a brief talk on glaucoma med washout and on a risk calculator technique that we use to also help us decide on whether to discontinue a glaucoma medication on a patient. I think this kind of relates to, we all have had patients come into our office and for the first time, and they say, I've been diagnosed with glaucoma for 15, 20, 25 years. I've been on this glaucoma med during that time. And we go through our eye exam, and everything really looks very good. The cup to disc ratio is normal. Visual field looks good. OCT is all normal. And we wonder, does this person really have primary open angle glaucoma, or are they more of a glaucoma suspect or ocular hypertension? We really don't know where they're at. And so we're trying to determine, does this person really need to be on a glaucoma medication? And I just want to preface this by saying this doesn't really relate to the secondary glaucomas. We're not really discussing like traumatic glaucoma, uveitic glaucoma, or exfoliative glaucoma, or really advanced primary open angle glaucoma where they definitely do have glaucoma. So this is really relating more to does the person really need to be on the drop or not? And as we go through our exam, we'd go through our basic glaucoma tests, but there's also other considerations that we may want to consider in deciding whether to continue on the eye drop for this patient or not. Some other patient considerations whether to discontinue glaucoma drops could be they just recently had cataract surgery. In our practice here at Tucson Eye Care, we do a lot of cataract surgery, and we know that that drops the pressure 2 to 4 millimeters of mercury. And they also may have had a MIG with their cataract surgery. So after that, we may want to plan on discontinuing the glaucoma medication. Also with SLT, selective laser trabeculoplasty, after that procedure, we may want to stop the medication. And then there's central cornea thickness. You know, if you reflect back 15, 20, 25 years ago, this was not really an emphasis in glaucoma management. And maybe patients were put on glaucoma medications who really had a thick cornea that didn't need to be on the medication. And I think we've all had patients who have ocular irritation, dryness, allergy. They may move here from another area of the country and they're really struggling with these. And the glaucoma medicine also is very irritating for their eyes. And they're asking, doctor, can you help me out with a different medication, or do I really need to be on the medication? And then there's also the patients that are challenged by expense and compliance. They may have lost their insurance. They may have a big increase in their copay or other financial challenges. They may not be complying with using the drugs. They may even mention that to you, that they're only using the medication every other day and not using it on a regular basis. And age is a consideration too. Perhaps the patient is over the age of 90. They're in a nursing home or under the care of a caregiver who logistically has a difficult time being able to deliver the medicine to the patient or administrate it. And then obviously within glaucoma, there's always been different doctor thresholds, different parameters to when to treat and not to treat. And for instance, age is one of them. There's some doctors who may be more aggressive at starting glaucoma care in a person who's 40 or 45 if they have a borderline pressure and a nerve that's kind of borderline. They don't want that patient to lose nerve tissue at the age of 55 or 60. So they may have been a little more aggressive about starting the glaucoma medication. And then there was the development of prostaglandins in the late 90s. I think we all remember that what a big improvement that was compared to previous glaucoma medications. And I think that kind of tilted the scale to doctors maybe being a little more aggressive about treating glaucoma and starting a glaucoma medication. And then there was also around the year 2002 where there was kind of a big push for neuroprotection to protect the optic nerve. We saw some of the pharmaceutical companies kind of promote, even if the pressure was 19, 20, 21 in a healthy nerve, to even get the pressure lower since the medications were so safer and protect the patient from getting glaucoma. And also there's always been the debate in our minds and with our colleagues, is it ocular hypertension or is it really primary open-angle glaucoma? When do we treat, when do we watch? And so that could lead someone to being put in an eye drop and on it for an extended period of time. So let's say we go through that eye exam and we take a few of these considerations into play, and we decide that, you know, we're going to take the patient off the eye drop and reassess where they're at, reassess where their eye pressure is at and where the glaucoma is really at. But if we do that, it's important to realize that the burden of proof is on the doctor, it's on you, that the patient does not have glaucoma. We need to make sure that the patient is at low risk for glaucoma. Because remember, there was a doctor, an eye doctor, who put them on that glaucoma medicine and told them they had glaucoma, and they're of that mindset that if they don't take this medication, they may go blind from that drop. So it really falls back on you to prove they do not have glaucoma. So obviously a lot of you know this. How do we do that? Well, in the doctor glaucoma assessment, there's always the basic tests and evaluation we go through, and you all know this. It's the IOP, the cornea thickness, C/D ratio of the nerve, visual fields, OCT, the angle, anterior chamber evaluation, patient history, family history, and any systemic history that may come into play. So we gather all this information, we look at it with the patient, and we say, oh, this parameter is good, this one is good, this one's kind of iffy, this one's good. I think overall we can, you know, consider taking you off the glaucoma medication. However, you and the patient may wonder, well, how does this really compare to other patients? How does this compare to a broad population? The information you're showing me here, it still seems to have a very individualized evaluation to it. Can I compare it to a larger population? And there is another tool that we can use, and that's called the risk calculator tool, which is based off of results from the ocular hypertension treatment study, the OAT study, and the European Glaucoma Prevention Study. And it estimates the 5-year risk for developing primary open-angle glaucoma. it's going to give you, the calculator is going to give you a percentage risk of the patient developing glaucoma in 5 years. So it may be like 10%, 30%, 40%. And it's emphasized, the study emphasized that this calculator is designed to be an aid but not replace clinical judgment. And the calculator comes in two methods. There's a continuous method and the point system method. Both of them are going to have you enter in glaucoma test information, and both of them are going to give a pretty similar percentage estimate of developing glaucoma. In our practice here, we use the point system. So I just want to show you that this is what they consider the risk calculator, the point system. And you can see on the left side here, there's 5 major factors: age, IOP, central cornea thickness, vertical cup disc ratio, and visual fields with Humphrey or octopus with looking at pattern standard deviation. So obviously, as you go from the left side to the right side, you gain more points. And the more points that you gain on this increases the risk of developing glaucoma. So obviously, you all know if the eye pressure is high or the central cornea thickness is thinner, the cup has a larger disc, cup size, the age of the patient is older, and the visual field has more pattern standard deviation, that's going to give you higher points and give you a higher estimate of developing glaucoma. So if you look down at the bottom here, you sum up those points, and that translates into the percentage. So someone with 11 or 12 points will be 20% risk. Someone who's 7 or 8 points will give you a 10% risk. So we had a patient here, for instance, an example, 72-year-old who had cataract surgery here, history of dry allergy eyes. She had some cost concerns with her medication. And after the cataract surgery, we obtained several measurements of her IOP. It averaged to 18. Her cornea thickness was 607 on the thick side. Of concern was her vertical C to D ratio of 0.7. But I will mention that her OCT was normal for the nerve, and her visual fields were pretty good, only 1.91 on a pattern standard deviation. So when you add up all these numbers on the point risk calculator, the age provides 3 points, IOP and cornea thickness are 0 points each, the vertical CD is 0.7 for 4 points, and the visual field only represents 1. We add that up and we get a total of 8 points, which translates into 10% estimate of 5-year risk of developing primary open glaucoma. And in our practice here, our doctor's threshold is around 25 to 33%. So if it's less than that, like this 10%, it gives us more confidence to tell the patient it's reasonable to stop the glaucoma medication and monitor the patient from there. If it's above 25, 33%, it may kind of tilt us to wanting to continue staying on the glaucoma drop. So in this case, we felt comfortable stopping the drop. And so for the glaucoma washout, basically we stop the latanoprost and we wait 2 months to do an IOP check after stopping the medication. You can do an IOP check at 2 weeks or 4 weeks, but the medication can still be in their system. So we want to wait a full 2 months to get an accurate measurement of their IOP. If the IOP is normal and we think they don't need to be on the glaucoma medicine, we'll check them 3 or 4 IOP checks through the first year. We'll do a 6-month visual field and OCT, and if that's normal, we'll check them annually. And if the patient's off the medicine, hopefully they're happy. So I just wanted to mention, if you do get a report from our office here back in regards to a patient that we evaluated for glaucoma, you may see that little column down there where it says glaucoma risk 10% or 20%, and they're getting that percentage from that risk calculator from the ocular hypertensive study. So if you wanted more information on that risk calculator for yourself, you can always Google just risk calculator, the OAT study, and it'll bring up that one as well as the continuous method calculator. So that was my presentation. I just really want to thank you for joining us this evening, and I look forward to seeing you in person in the near future, hopefully. Thank you very much.
Okay, hi everybody. My name is Emily Wright. Thanks for joining us this evening. I'm going to give a brief glaucoma update on the light trial and the MIGS techniques that I'm doing here. So the light trial is a 2019 landmark glaucoma study. It was looking at SLT versus eye drops as first-line therapy for patients with ocular hypertension or open-angle glaucoma. It was a randomized controlled trial, 6 UK hospitals, 2012 to 14. Again, POAG or OHTIs randomly allocated to initial treatment with SLT or drop therapy. And the SLT group could undergo multiple treatments as needed, and the eye drop group could escalate therapy to either laser or incisional surgery as needed. Interestingly, the primary outcome of the study was actually health-related quality of life. And for the purpose of this talk, the outcome that I'm going to focus on is the clinical effectiveness of the study, but they also looked at cost effectiveness and safety. So this is a table basically demonstrating that it was in fact a randomized controlled trial. You can see that the eye drop group and the SLT group are very similar in their parameters, most notably visual field, HRT, optic nerve baseline characteristics, and IOP. So findings of the study, 718 patients were enrolled, 356 to the SLT group, 362 to the eye drops group. There was no significant difference in the EQ5D score, so that was the quality of life survey that the patients took, and that was actually surprising to me. I expected the eye drop group to have a lower score there. At 36 months or 3 years, 74% of patients in the SLT group required no drops to maintain IOP level at target, and eyes in the SLT group were at target at more visits 93% of the time than the eye drop group, 91.3% of the time. Subsequent glaucoma surgery was required in 11 patients in the eye drops group and 0 patients in the SLT group. And over the course of 36 months, or again 3 years, there was a 97% probability of SLT as the first line treatment being more cost effective than the eye drops group. So in this table, the big thing I want to point out is, again, in the SLT group, they could undergo multiple treatments. So you can see about 26% of patients did require more than one laser. And then the other notable finding in this table that I'll point out is about 68% of patients in the eye drops group were maintained at target pressure on one or no medications at 36 months. So about 32% of people did require more than one drop. In this table, there's 2 findings that really, in this study, that have persuaded me to kind of change my practice patterns, and I'll point out the 2 things. The first we already mentioned, so it was pretty remarkable to me that 11 of the patients in the eye drops group actually required a trabeculectomy versus none in the SLT group. And then the other finding, 5.8% of the patients in the eye drops group did progress during the course of the 3 years versus only 3.8% in the SLT group. So implications of all of the available evidence of the study: SLT is associated with lower cost, good clinical outcomes, lower symptom scores, and drop freedom for most patients, and should be offered as an alternative to IOP lowering medications. So one of the big reasons I wanted to include this study in our talk is because these patients are great candidates for co-managing with our optometry colleagues. An evaluation for SLT, all of these patients do need a gonioscopy, and then we schedule a separate laser procedure visit, and it takes about 6 to 7 weeks for the full effect of the laser to kick in. And you know, if they're at target, if they're one of those 74 to 80% of people who meet the target pressure, if you're comfortable with it, we can send them back to you and co-manage those patients if that's something that you're interested in doing. So in conclusion, strong consideration should be given to offering SLT as first-line therapy in the treatment of POAG and ocular hypertension, which is supporting a change in clinical practice. So I want to shift gears a little bit now to the MIGS procedures. The ones that I have adopted mainly in conjunction with cataract surgery are the Cahook dual blade and the Omni surgical device. So the KDB, you may be aware, is a goniotomy procedure. It's excising about 3 to 4 clock hours, or 25 to 33% of the internal drainage pathway. And the Omni surgical device is a dual mechanism device. It achieves a viscocanaloplasty, so it's injecting viscoelastic material into Schlemm's canal and into the collector channels to open up those collapsed canals and channels. And then the second portion of the procedure you can see in the bottom right here is the trabeculotomy, where a microcatheter is used to unroof the trabecular meshwork. So I've done approximately 80 combined cataract KDB cases, and we have 26 that we have follow-up after 6 months. And one of the things I've noticed in looking at retrospective surgical outcomes for glaucoma is it's very challenging to get meaningful data, but I did my best here, and my scribe, Dannon, worked very diligently to get this data, so thanks, Dannon. So the first bullet point here, the percent of eyes with 20% IOP reduction were 46%. There is a confounding variable here, so patients who have similar pre and post-op IOP pressures may have gotten off a drop. So you think about a patient who may be on dorzolamide timolol before a cataract KDB procedure with a pressure of 20, and their pressure is 18, that's a 10% reduction, but maybe they got off that combined drop. So that's a 2-drug reduction in their drop burden. Similarly, the second bullet point here, a similar confounding variable, but the average overall percentage reduction in IOP was 16%. The percentage of patients using 1 or fewer drops was 62%. The average decrease in drop burden was 0.7. That's a little bit of an elusive data point, but I think the takeaway there is you can say more likely than not, if a patient's on a drop, they will get off of it. And then of the only 2 of the 26 patients required additional treatment, 1 of whom I did need to do a trabeculectomy 14 months out. 9 of the patients had 1 drop reduced, 4 had 2 drops reduced, 11 had no drop reduction, but 3 of those 11 actually were not on drops prior to surgery. So KDB is approved actually for ocular hypertension as well. And I thought these 11 patients would be a useful kind of subset to look at further because their pre and post-operative drop burden was the same. So of those 11 patients, they had an overall 19% reduction in IOP compared to the 15.8. And 7 or 64% of them had a greater than 20% IOP reduction compared to the 46% here. And then for the Omni procedure, I've done about 10 to 15 Omnis, either standalone or in conjunction with cataract surgery. And I've really had been reserving this technique, truthfully, for patients with severe glaucoma who are very reluctant for incisional surgery. And the main reason for that is because there is no data on the device, but actually just a few weeks ago, this Omni Gemini study came out with their initial 6-month data. So it's a prospective multi-center control trial, and they use patients with mild to moderate open-angle glaucoma, so not the severe glaucoma patients. There were 76 patients in the study on 1 to 4 IOP lowering medications. There was a 75% reduction in the use of IOP lowering medications. 73% did not require drops at 6 months. And of those 56 patients, they had an overall 40% IOP reduction compared to their washout pre-op IOP, and 95% of those had a greater than 20% IOP reduction. Adverse events, hyphema, IOP spike, vitreous hemorrhage were rare and self-limited, but they do happen. And then none of the patients in the study required incisional surgery at 6 months. And I just wanted to mention one of my cases. This was a very sweet 83-year-old female who had presented to me with severe primary open-angle glaucoma. She had a pressure of 34 in her left eye on Combigan, Azopt, and Vyzulta. And she was very reluctant for incisional surgery, tried to talk her into it, but did not want a trabeculectomy. So I took her for a 360 viscocanaloplasty trabeculotomy with the Omni surgical device. And she was pseudophakic, so it was a standalone procedure. And at post-op month 15, most recently, her pressure is 15 on Zioptan alone. So that's a 56% IOP reduction with a significant reduction in her drop burden. And most importantly, her disease status has stabilized, preventing the need for incisional surgery. So this is really a slam dunk. This by no means can be extrapolated to all of my outcomes, but it's something that is worth mentioning because for this lady, just really huge for her quality of life, not needing to undergo a trabeculectomy. Okay, these are my references. Thank you very much for joining us, and please stand by for Dr. Jonathan Gross.
Hi, I'm going to report on the experience at Tucson Eye Care with Natarsadil, brand name Ropressa, which we've had available for about 2 years now. I have no financial interest in Ropressa or Aerie Pharmaceuticals. It's surprising to me, but there seems to be next to nothing in the current literature about Ropressa as an adjunct glaucoma medication, which I think was its intended use from the time of its introduction. Aerie Pharmaceuticals has recently started advertising results of their in-house data on its use as an adjunct, but haven't published anything yet. I'm going to say a little bit about the drug and how it works, and then present data from roughly 1/3 of the patients in our practice that have used this drug. Here's your favorite bit of algebra, the Goldman equation. Before you fall asleep, I just want to remind you of the basic factors in play in pressure control: aqueous formation, uveoscleral outflow, facility of outflow, which involves the conventional pathway of trabecular meshwork and Schlemm's canal, and episcleral venous pressure. Rho is the name for a group of proteins found all over the body that bind enzymes involved with cellular contractility, among other things, including cells in the trabecular meshwork, Schlemm's canal, and smooth muscle, as in episcleral veins. Ropressa is a Rho kinase inhibitor, and has 3 different mechanisms by which it lowers pressure. The most talked about is its increase in outflow facility, but it also has activity against norepinephrine transport, which decreases aqueous production, and it decreases episcleral venous pressure by relaxing smooth muscle cells. Other meds used commonly for glaucoma either increase uveoscleral outflow or suppress aqueous production. So the increase in conventional outflow facility and the decrease in episcleral venous pressure are presumably the main factors by which Repressa acts to decrease IOP when added to other glaucoma medications. We have about 300 patients here who have been on Notarsidil, either as Repressa or Rocklatan. I reviewed about half these charts and identified 95 patients who were prescribed Repressa, didn't have other medication changes or surgery in the period studied, with a total of 122 eyes being treated. This is a retrospective review, not controlled. All of these patients were taking or had taken other glaucoma medications. The baseline used for pressure was the IOP on the date that Repressa was prescribed, and the pressure change in subsequent visits was recorded. Many of the patients had only 1 or 2 visits after it was initially prescribed, either because they were prescribed it only recently, or they stopped taking it because of side effects or lack of efficacy, or they went on to surgery, or simply didn't return for follow-up. Compliance with Repressa and the other patient medications was not controlled, and so may have affected the results. Our patients are really old. Patient ages ranged from 38 to 96, with only 6 under 60 and 8 in their 90s. The average age was 80. The vast majority of patients had primary open-angle glaucoma. 6 were diagnosed as low tension, 7 pseudoexfoliative, 3 pigmentary, 5 mixed mechanism, 3 uveitic, 1 steroid-induced, 1 neovascular, 1 juvenile, and 2 traumatic. Most patients were on multiple medications, the average being about 3 per patient. 5 weren't on any meds and 12 were on just 1 due to either patient intolerance of side effects or lack of efficacy. 58 had undergone at least 1 SLT, 22 had either trabeculectomies or shunts, 7 laser cyclophotocoagulation procedures, and 62 had had cataract surgery. The range of pressures across all patients prior to starting Repressa was 10 to 34. The average drop in pressure, including all patients, on the first visit following the initial prescription of Repressa was 3.7, which is about a 17% drop. I also looked at a group of patients who had 3 or more IOPs taken since starting Repressa. In my own practice, this would translate to a time period of at least a few months of use, up to a year, depending on the particular patient. There were 33 such patients with a total of 43 eyes treated, with starting pressures ranging from 12 to 29. In this group, using the first 3 IOPs taken for all patients, the average pressure drop was 4.6, or about 22%. The group with 3 pressure readings comprises patients who continued on Repressa because they were getting a significant IOP response and not having severe side effects early on, so their numbers look better. I also looked at patients starting with relatively low pressures compared with patients having relatively high pressures, because in the FDA phase 2 and 3 trials, Repressa performed less well than timolol in patients with pressures of 27 or higher, but better than timolol at 26 or less, and showed a consistent IOP lowering of about 4 points in patients with baselines in the low to mid-20s. We had 17 patients and 18 eyes with IOPs of 25 to 34, the higher pressures group, and their average IOP drop was 4.8, or about 19%. We also had 18 patients and 20 eyes treated starting at IOPs of 15 or less, the lower pressures group, and their average IOP drop was 2.5. Facility of outflow is pressure dependent, so you would expect less effect from Rhopressa at lower IOPs, but 2.5 is still about a 17% pressure drop, and in patients already on multiple meds with low pressures, I think that's a good result. 58 out of 95 patients did not report side effects. Red eyes were the most common complaint. And again, we were talking about patient-reported symptoms, not slit lamp findings. Red eye complaints were noted in 27 patients, followed by 7 with excessive tearing, 6 with irritation of some form, 4 with eye pain or tenderness, 3 with skin rash, 2 with lid swelling or soreness, and 3 with blurred vision. 37 patients discontinued the drop, 25 because of side effects and 12 because of lack of efficacy. The bottom line, I think, is that if you prescribe Rhopressa, you can anticipate that most of your patients will get a significant IOP lowering effect, regardless of whether they are using multiple other medications. And you can anticipate red eyes and various other complaints in many of those patients. Because of its side effect profile, I think Rhopressa is and will continue to be relegated primarily to the role of a third-line drug. I personally find it most impressive in patients whose pressures are already in the mid-teens or lower, often on 4 medications, who I now see getting as low as the single-digit range with the addition of Rhopressa, which I used to see only in surgical patients. Rhopressa, in fact, is often my last step now before a surgical consult. That's it for me. We're going to get you a fresh new speaker and be right back. Thanks for watching.
Thank you. I'm Bob Snyder. I'm going to talk about my favorite subject tonight, and that's going to be macular degeneration. I've got some additions to, some new and very important additions to some of the things that I've told you before. And we're going to start out talking a little bit about some of the basics. Neovascular macular degeneration is a leading cause of vision loss in the United States. Prior to the widespread use of anti-VEGF, it was believed to account for about 90% of vision loss attributed to neovascular macular degeneration. There are about 200,000 new cases of NAMD in the United States each year, for an approximate total of about 1.5 million NAMD. And NAMD is neovascular AMD. It used to be referred to as wet macular degeneration, and now, if you want to be cool, you got to call it NAMD and not wet macular degeneration. So, as I said, 1.5 million cases total of NAMD in the United States, and probably an equal number in Europe. And that number is expected to double between now and 2050. Now, the current treatment is with anti-VEGF injections, and these were introduced a number of years ago. And since they were introduced, the vision has dropped, or the loss of vision has improved by 50 to 70%. In the CAT study, which was one of the first and early studies large studies of anti-VEGF therapy, about 34% of the patients gained 3 lines or 15 letters in visual acuity at an average cost of about $23,400, while only 6 people lost 3 lines of vision during that course of that first year of the study. Problem was the vision gains were not always stable. A 5-year follow-up of that same CAT study showed that the mean visual acuity declined by 3 letters or worse than baseline, and 11 letters worse than it was at 2 years. So it's not quite the panacea that you would like to think. And not only that, but it's very expensive. Anti-VEGF injections cost Medicare Part B nearly $8 billion annually in the United States. It's a #1 line item in Medicare Part B. The injections and medication cost up to $2,300 each, and they're repeated about between 7 and 8 times per year. This is just a graph that shows you what's going on with the type or the Part B spending, and basically it's just escalating. And as I said, the number of cases continue to increase, and it's cumulative. It's just added on to what's already there. Anti-VEGF injections also have a personal toll, and we often don't think about that, but you know, for many people that are having these injections, their life really almost revolves around their injection schedule. It can be pretty disruptive for some of them. They have to make plans for the visit. They've got to have somebody that can drive them there, take them back. Recent studies have found that patients with NAMD are often undertreated, and as a result, the visual potential may not be optimized. And the reason they're undertreated is they miss their appointments, or they don't want to go, or they have gaps in their appointments, sometimes as much as 100 days in between appointments. Another study found that approximately 20% of patients were lost to follow-up, and this again resulted in visual loss. In view of that overall burden, the cost, and the personal toll from NAMD, I believe there's an urgent need for a preventive treatment, preferably in a pill or a drop form. And these were just some of the concerns that people have with the anti-VEGF injections. They're uptight, couldn't relax. They find it difficult to think about anything other than getting these injections. Affects their sleep. They seem more short-tempered and snappy. And in general, it does have an emotional toll. AREDS vitamins were introduced again many years ago, and they do have some positive effect in reducing wet or in AMD. The problem is probably the majority of these patients are already on AREDS vitamins, and yet the number of cases of wet AMD continue to rise. So there's clearly need for a more effective preventive strategy. Wet AMD is a result of VEGF, which is vascular endothelial-derived growth factor. It's secreted by the retinal pigment epithelial cells, and it's secreted from the basal side of the retinal pigment epithelial cells. And this is somewhat important in our approach to preventing wet macular degeneration. The retinal pigment epithelial cells have tight junctions, and that means that molecules can't get in between the retinal pigment epithelial cells, and they can't go from the vitreous side to the choroidal side effectively. In fact, they don't get there. Unless they're transported by the cell, it's not likely that they're going to get across. Now, that's important because anti-VEGF injections as an attempt to prevent wet AMD are not going to work if they can't get across the tight junctions of the RPE cells, and it's highly unlikely that they do. So we're looking for something else. And you all heard this story, bits and pieces of it. We'll review it quickly. GPR143 is the gene product for the ocular albinism gene. It sits on the cell surface of RPE cells. L-DOPA, which is an intermediate in the pigment pathway in the eye, is released by RPE cells, and it feeds back onto these cells and stimulates the receptor GPR143. When it does, it reduces VEGF release. Dopamine, which is also present in the eye, especially during the daytime, also binds GPR143 and with about the same affinity. So They both compete for the same binding site. Dopamine stimulates VEGF. So it's a yin-yang relationship, opposing activity. Stimulation of RPE cells with L-DOPA decreases VEGF, while stimulation of RPE cells with dopamine stimulates VEGF. It's like a switch, an on-off switch. And I'll go into the details a little bit in a second why that's important. Now, we hypothesize that a combination of L-DOPA, carbidopa plus melatonin, that's a new twist on this, we call it melodopa, will be effective based upon the following evidence. First of all, we have epidemiologic study that says if you're taking L-DOPA, it delays the onset of NAMD by up to 5 years, and perhaps more importantly, it decreases the odds ratio of getting NAMD by 0.65. So it's less likely you're going to get wet macular degeneration or NAMD, and if you get it, it's delayed. Now, this is a recent study that we just published, and it just came out in the American Journal of Medicine. It's going to be in the hard copy in January, but it's now available. If you go on PubMed, you can find it online on PubMed right now. And this was a study looking at patients that are naive to injections of anti-VEGF to see if we could find and identify a positive effect with L-DOPA. And when you think about it, if you're trying to prevent NAMD, that study can be pretty cumbersome. And when we started this, we hadn't quite figured out how to do that second study. But this was the most straightforward way to get what we think is a relatively unequivocal answer to the question, does L-DOPA have any positive effect on neovascular macular degeneration? So in slide A, what we did is we looked at the change in visual acuity in patients that were taking L-DOPA at 1 month. They had 4 letters, which is not a huge improvement, but it's not going south. In other words, they're not losing 4 or more letters or 3 lines of vision, which would be 15 letters. And at 6 months, that improvement maintained itself, and it was up over 5 letters, and this was statistically significant. In slide B, we look at the mean change from baseline in the central retinal thickness. And from going from 0 to 10, which is the first column there, that means that it improved by 10 microns. And we got a positive improvement in central retinal thickness in the overwhelming majority of these patients. On number 3, we look at the retinal fluid, intraretinal fluid in the areas of the wet macular degeneration, and again, the vast majority of these people, it reduced with L-DOPA, no injection, just L-DOPA. And then on slide D, it's just another way of graphing this, and you can see 2 of the 13 patients did not improve, and all the rest improved. So we'll go on. So basically, L-DOPA works. It reduces the fluid. And why do we have this combination of L-DOPA, carbidopa, and melatonin in this drug that we're going to call melodopa? And that is because carbidopa prevents the conversion of L-DOPA to dopamine in the peripheral circulation and tear film. So therefore, it enhances the amount of L-DOPA that's available to bind this GPR 143, whether it's in a pill or a drop form. Melatonin is a circadian signal, and it shuts down dopamine release in the eye in the daytime when the lights are on. And since dopamine also binds GPR 143 at the same affinity, you want to get rid of dopamine and you want to get rid of dopamine because it binds GPR at the same affinity, and melatonin decreases, downregulates dopamine, so it should synergistically reduce the amount of VEGF. In other words, indirectly, it'll reduce the amount of VEGF because it's decreasing the amount of dopamine and therefore decreasing the GPR 143 drive to release VEGF. So we have validated this in an RPE culture and continuous perfusion system, alternating L-DOPA, melatonin supplementation with dopamine. And we could get these cells to cycle in a circadian manner, releasing VEGF under L-DOPA control, under dopamine, and shutting down VEGF under L-DOPA. We then submitted a patent, and we found that melatonin was complementary to that. So we submitted another patent last year as a provisional, and then finalized it this year in January of 2020 for the melatonin effect on VEGF and decreasing VEGF. And it, as I said, is an indirect effect. And also important to this is melatonin is also an important antioxidant and probably stabilizes liquid formulations or even pill formulations of L-DOPA. And this is just a graph of our poster at ARVO last year. Again, just showing in one of these, it's a little hard for you to see. It's even a little hard for me to see right here. But melatonin has an additive effect in that. So what we propose to do now is to study to look at the prevention of NAMD. And we intend to use Meladopa in both a pill and a drop form to see if it can prevent neovascular NAMD. And why are we doing this? Well, one, it's got a really easy endpoint. And you can see it very easily on OCT. And it should be a pretty discrete way of looking to see if we can prevent NAMD. So what I'm going to get, this is probably the most important thing that we've done this year, and that is we're looking now, we've submitted an SBIR grant to the government to look to fund this. And we try to decide how could we look at a prevention study? Can you just take people off the street and give them an L-DOPA and see if you can prevent them from getting wet AMD? Not well, you'd have to look at a vast number of patients. What if you took people that are at sort of modestly high risk, those that already have wet AMD in one eye, have a 12.5% chance per year of getting it in the second eye? Well, we thought, gee, that might be a good idea. And can we do that? And the first thing you do is a power analysis to say how many patients would we need to study to see a positive effect. And if we did that, and we assume that we're looking for at least a 30% reduction in the conversion from intermediate AMD in the second dry eye, we're looking for a 30% reduction in that converting to wet over a period of a year. And we can do a power analysis, and it turns out we would need, if there's a 12.5% risk of converting, we would need 1,413 in each arm, the placebo and then the pill arm, or the placebo and the drop arm, or 2,826 patients. Now, if it costs about $3,200 a year to treat somebody, we're talking about $9,043,000. And that was beyond what Larry said he would help me fund. So we decided that wasn't going to work. And so then we looked at, how can we enrich that pool? And this is an important point. If you enrich the pool, you can markedly decrease the number of patients that you have to get into a study. And these power analysis, what that is, it's a statistical way of looking at how many patients do I need to look at to have a 90% chance of finding a positive effect if it's there with these endpoints that I'm looking at. So now if we go back and we say, can we find somebody that has 80% chance of converting to wet AMD? You do those same calculations and it turns out you need 78 people per arm. And that now at that $3,200 a patient comes down to a $400,000, $500,000 study. So that's feasible to do. The other is not so feasible to do. And this is, again, looking at an OCT image of the endpoints, and you can see over on the right some of the wet AMD slides, pretty clear endpoint. And the way that we're going to get the enrichment now is with a new technology called OCT angiography. You're all familiar with OCT images. Well, OCT angiography is virtually an OCT image, only instead of taking 1,000 a second, they're taking 100,000 pictures a second. So they take so many pictures that they can actually see the difference in the capillaries due to the red blood cells moving as time goes on. So within a second, they've taken 100,000 pictures, then they mathematically do some subtraction, et cetera, and they can look at where there's movement in the capillary bed, and they can actually find these lesions that are called non-exudative macular degeneration. What that means, this picture now in section A is underneath the retina, and these abnormal blood vessels that are in that sort of gold appearance, those are underneath the retina. There's not frank exudation yet in the retina, and those are what they call non-exudative. They're probably leaking, but they're not leaking enough fluid that it accumulates in a dome underneath the retinal or intraretinal. So these are very early, they're nascent. And if you follow the history of these, about half of them stay about like this size, and the other half grow. And the ones that are growing, according to a recent paper that's out there by Dr. Wong, who was the inventor of the OCT and the OCTA, or at least the OCT, he says that about 90% of these will convert to wet. And that's a very small study, so we really don't want to quite hang our hat on it yet. But this is a schematic on this next slide where they've got an in-face. In other words, instead of looking at the slice, you're looking at a flat section right below the RPE, where you can see the area in microns squared has increased over a 5-month period. These patients, we think as many as 90+% will go on to develop wet AMD. And this is just a slide showing, as time goes on, how many of them convert to wet AMD. As I said, David Wong is the leader in that area. And so what we're proposing in this SBIR is to go first to do a clinical trial where we look at, we're going to scan patients that already have wet AMD in one eye, and we're going to scan them in the second eye, and we're going to see how many we have to scan in order to find a pool of patients that have non-exudative lesions in their second eye. And then we're going to see what percentage of those that have non-exudative lesions convert to wet in 1 year. Once we have those numbers, then we can do a power analysis similar to what you see on this table. So at present, I said we do not know the conversion rate from non-exudative NAMD to exudative. We need to know this before we can estimate how many patients we need for a study and do the appropriate power calculations. There was a study just recently put out by a big shot retina guy. He looked at about 110 patients in each group that were injected with either a sham injection, so they still got a needle in their eye every 3 months for 2 years, or an anti-VEGF agent. And I think the sham group had 11 conversions to wet, and the treatment had 10, and he concluded that there was no effect. Well, he had just grossly underestimated how many people he needed to look at to find an effect. So in order for us to make this power calculation to figure out how many we need to study to determine whether we can have a good chance of finding an effect, i.e. a 90% chance of finding an effect, we need to know what the conversion rate is first from dry to wet in this high-risk group of non-exudative lesions. And if you see the sample size chart, it says the sample size needed per arm to achieve a 90% power, in other words, a 90% probability of finding a statistically significant event if in fact it exists. So if you look at the treatment conversion rate, if we want to try to prevent 30% of them from converting, and we've enriched it to a sample size that if you didn't treat them, 90% would convert, we only need to look at 50 patients in a year in each group. So that's easy to do. So that's what we're intending to do. And these are just the specific aims of our SBIR. And that is, one is to define and refine the potential criteria for finding these high-risk non-exudative NAMD lesions, and measure their size, growth, and vascular patterns, and then calculate the coefficient of correlation for each of these conversions to exudative NAMD, and then obtain that 90% usable images. And what we want to do is be able to get these images so we can do it every time and do it right. And then we want to determine the conversion rate of 60 patients to NAMD over a year. And then we want to use that data to design a legitimate phase 2 clinical trial of oral or topical L-DOPA with melatonin to prevent or delay the development of NAMD. And it's a huge market. And then what we are looking to do is to try to find a pharmaceutical company to partner with us at this stage, because, you know, we can't take it much further. That would be this study we think is going to cost us about $2.5 million. And then to go into a legitimate phase 3 is probably 10 to 20 million. So if you look at the market potential just in North America and Europe, those that are at high risk for NAMD in the second eye, and that's a very select group. And if we can show efficacy there, my suspicion is people that are concerned about it, that just have intermediate AMD and are perhaps progressing you may even get a higher percentage of people that will become candidates. But if we just looked at the ones that already have wet AMD in one eye, and now you're worried about their second eye, there's a lot of these patients out there. And so we estimate the potential utilizers in this new group would be approximately 2.1 million. So annual sales at just $1.50 a day, a very inexpensive drug. If you had 100% penetration, it would be a $766 million potential. If you got 30% penetration, still $229 million potential. And it's interesting, most of the drug companies won't even look at anything unless it exceeds $100 million a year in potential sales. So anyway, we're optimistic. We're continuing on the same path. We're trying to be diligent and persistent. So thanks for your attention. And if any of you have any questions about it, feel free to catch me sometime and I'll go over it with you again. Okay, so that'll wrap it up tonight. Feel free to call any of us if you have any questions on what we presented. Thank you very much for participating. Somebody have a question?
Can you hear me?
I can.
Thanks so much. It was definitely worth the watching and wait, and we really appreciate it.
Well, thank you. You're welcome. Now I've got Larry is here too. So anything that doesn't have to do with macular degeneration, Larry can answer everything else. I know that. So
have a great evening.
Okay. Thanks a lot. Did you want to say something, Larry?
No, I'm good. I'm just
Okay. Okay. Signing off.